Everybody. Good evening. Hi. I'm going to grab seats, scoot in a little closer, make some friends. I'm Yvette Moy. I'm the University of Washington's Director of Public Lectures, and I'm so glad to welcome you all here tonight. For our lecture, we are going to welcome Professor Carey Candrian, and her talk is titled Healthcare Where All Can Thrive, Advocating for Older LGBTQ Adults. Professor Candrian will be introduced by UW Professor of the Department of Pediatrics, Dr. Doug Opel. So many words. And Dr. Aaron Cross, who is also the director of the Cambia Palliative Care Center of Excellence at the UW School of Medicine, will moderate tonight's Q&A. I have a few folks to thank who helped bring Dr. Candrian here and make this visit possible. That includes the University of Washington Department of Pediatrics, the University of Washington, that's right, you can shout, yeah, applaud yourselves, that's good. The UW Disability Studies Department, one of my favorites, UW School of Medicine, Seattle Children's Hospital, and Seattle Children's Research Institute. Thank you all so much. So I have a few housekeeping items to go through before we get started. The first is if you haven't done so already, please silence or turn off your cellular devices. We ask that you refrain from video or audio recording tonight's lecture. We are live streaming. Hello, everybody in live stream land. And you can find this recording on the Office of Public Lectures YouTube channel. We also ask that you please refrain from taking photos while our speakers are on stage. It's just very distracting. Tonight, there are two ways to ask questions for you brave souls that are in the audience tonight. You can walk right up here to the microphone and ask a question, provided it is in the form of a question and it is relevant to the topic at hand. We'll let you know if it isn't. And then for those of you who are feeling a little more timid or shy, and for those of you watching on the live stream, you can, we have a little QR code that usually is up here, and you can scan it and you can send in your questions that way, and they can be upvoted as well. And with that, I'm going to welcome Dr. Doug Opel to the stage. And as Dr. Opel's making his way up here, I'm going to encourage all of you to introduce yourselves, if you don't know one another, to one another and say hello. Make a new friend tonight. Thanks.
Well, good evening again, and thank you, Yvette. It's really a pleasure to be here with all of you, and it's my distinct pleasure to be able to introduce our speaker for today's lecture. So Dr. Carey Candrian is an associate professor in the Division of General Internal Medicine and director of the Science and Communication Lab at the University of Colorado School of Medicine. She also serves as a Health and Aging Policy Fellow with the U.S. House of Representatives, working on the minority staff of the Committee on Ways and Means, Subcommittee on Health. Dr. Candrian holds an MA in Organizational Communication and a PhD in Health Communication, both from the University of Colorado. Her work bridges research, policy, and storytelling to advance health equity, particularly for LGBTQ communities. She is the creator of Eye to Eye, Portraits of Pride, Strength, and Beauty, a powerful photo exhibit celebrating older LGBTQ women, and the director of the documentary Just Us, The Longing and Hope of LGBTQ People, which explores the lived experiences and resilience of LGBTQ individuals, and which I had the pleasure of seeing yesterday. So with that, please welcome tonight's guest, Dr. Carey Candrian, to the stage.
Thanks so much, Dr. Opel. All of you, thank you for being here. Yvette and Kate, Jory, Aaron, Dr. Cross, everyone. It means a lot that you're here. I'll just wait 1 minute until the slides are up. Great. So at this point, you know I am Carey, and I'm a health researcher at the University of Colorado School of Medicine. And for the last year, I've been a fellow with the U.S. House Committee on Ways and Means in Washington, D.C., where I've been working on health policy. Throughout my career, I've really been focused on improving the way older LGBT people are cared for, and especially around serious illness and end of life. As you can imagine, serious illness, end of life is hard. It's hard for everybody, but it's even harder when you're LGBTQ. The obvious question is why? Why is it so much harder? And they're basically navigating serious illness and end of life with three major disadvantages. The first is health discrimination. There are 56% of LGB people report experiencing some type of discrimination from a healthcare professional. For those who are trans or gender nonconforming, it jumps to 70%. At the same time, people who are LGBTQ are disproportionately at risk for a variety of health disparities. They have higher rates of cardiovascular disease, certain cancers, dementia, anxiety and depression, and suicide. A second reason why it's harder is financial. 1 out of 3 LGBT adults live at or below the poverty line, a third. And this is for a number of factors. Most of these people have faced job discrimination for their entire lives. A lot of the financial is also directly related to the fact that many LGBTQ people have very thin networks of support. Compared to the general population, many of them end up living on a single income, and many of them are less likely to be married, which also means they're aging without often access to spousal benefits, pensions, Social Security, things that really matter when you age and face a health crisis. They're also 3 to 4 times less likely to have kids. They're more likely to be estranged from their biological families because of rejection. So in addition to fewer financial resources, they're aging with less overall help with care, support, and advocacy, which we know really matter when you're facing something like serious illness. Third, and really underlying all of this, is a lifetime of stigma and discrimination, which, according to Harvard Medical Magazine, can take up to 12 years off their lives. How does stigma and discrimination have such an impact on this community? Let me give you some context. When I talk about older LGBTQ people, I'm talking about people who grew up in the 40s and the 50s and the 60s, when being LGBT was completely taboo. It was illegal in most states and really dangerous. People lost their homes, their friends, their family, like Anne did. And some of you might know that up until 1973, the American Psychiatric Association listed homosexuality as a mental disorder. Just imagine growing up thinking that there is something that wrong with you, that you are sick because you are LGBTQ, how vulnerable you would be, and how much you would internalize the stigma. And even though the laws have changed, the APA has changed, the stigma has stayed. And it affects the way LGBTQ people move through the world, what they share and what they don't. And things, unfortunately, are not getting any better. Just this year, actually in October, the Movement Advancement Project surveyed over 1,000 older LGBTQ people. They found that a quarter of LGBT adults and more than half of trans and non-binary adults have taken concrete steps to become less visibly out in their communities, their schools, and their jobs. Some have even moved to different states. I know several people who are actively trying or who already have left the country just to stay safe. For most of my career, I've really wanted to understand what was specifically behind all this, the disparities in outcome, the fear and stigma, and its effects on health, all of it, and what we could actually do about it. As a healthcare researcher, and like most researchers, I deal with data and statistics and numbers a lot. But the numbers haven't always been able to tell me why and how these things have come about and what we can really do about them. So a decade ago, I did what researchers call qualitative research, or I started qualitative research. And since then, I've done just over about 200 in-depth interviews with LGBTQ older adults about their experiences with healthcare. And the more I heard their stories, the more I listened to them, the more I realized there was such a strong connection between communication and health disparities and outcomes. Literally, the way people communicate, the way people were talking and listening were having concrete effects on someone's care. And changing this can actually make a measurable difference in someone's care. And a huge amount of the way we communicate is directly related to habits of communication and also culture. One of the women I've met in my research and who I interviewed was Pam. Pam grew up in New York, and when I talked to her, she was telling me about growing up in the 50s. She was a copywriter, and how hard it was, and how dangerous it was, and how she didn't even have the words to describe herself. I'm going to play this clip. She's actually in it. She's talking about a 1961 film, The Children's Hour, with Audrey Hepburn and Shirley MacLaine. Here she is.
It's Lillian Hellman, and in short, there's two young women who are running a girls' school, and it turns out that one is a lesbian and one isn't, and the one who is killed herself. So it's not a happy story, but for me it was fabulous to find out that that category of person existed. So I would say from 8th grade on I kind of knew it, but the vocabulary, gay and owning dyke and all of that didn't happen until basically after Stonewall. Stonewall happened when I was a senior in college, and so the vocabulary to describe myself came out in the 70s.
To give you a sense of just how pervasive these norms were, here's Pam again.
It was the summer I was 21, about to go into my senior year of college. And up until then it was incredibly dangerous to even think you were gay, but
So is it any surprise that older LGBTQ people who grew up in this culture have honed what I call this habit of silence about themselves? And they've hid themselves for decades. This woman, Shirley, didn't come out until she was writing the obituary for her wife of 38 years. She was 81. This habit of silence is still happening, and it exists as a critical defense strategy for this community. It exists in general in all aspects of our lives, but importantly for us here tonight, it also exists in healthcare. 48% of LGBTQ adults, almost half, say their own doctors and those who care for them don't know they're LGBTQ because they're afraid if they tell them, their care will get worse. And they're not crazy for staying silent or worrying. Discrimination can and is happening all over the healthcare ecosystem, including places like assisted living and hospice. In a 2020 survey of over 850 hospice respondents, which were hospice professionals, 45% of the staff said that they directly observe discriminatory behavior towards LGBTQ patients. Things like rolling eyes when patients were holding hands, not including the partner in decisions, and even disregard of patient wishes. And unfortunately, things haven't gotten much better. Last year, the Kaiser Family Foundation did a survey of over 6,000 LGBTQ adults, and they found that 65% of them reported experiencing some type of discrimination in their daily lives. And this discrimination is having concrete effects on their lives and their health. In terms of physical health, from this survey, they found that a quarter, 24% of LGBT adults reported experiencing a negative healthcare experience in that year. And 39% of them said that this made them less likely to seek care because of these experiences. 6 out of 10 LGBT people said they prepare for insults or feel like they need to be careful about their appearance to be treated fairly. In the same survey, in terms of the impact the discrimination is having on mental health, 68% describe their mental health as fair or poor, and 46% said that they needed healthcare services but couldn't get them. This is a lot of extra work and stress to think about and worry about when you're facing healthcare and facing something like a serious illness. And I know I just threw a lot of statistics at you that may or may not stick. But what I would like you to remember is that there are real people behind these statistics being affected by these numbers. People like this woman. People like Esther, a woman I met 3 years ago. Her story and others like hers are the reasons I continue to do this work. When I met Esther, she'd recently lost her wife, Kathy, to cancer. During her illness, Kathy had been open about their relationship. But when the staff realized they were a couple, Kathy's care got worse. So they hid their relationship. Through it all, through Kathy's illness, through her treatment, and ultimately her death. Because they were hiding their relationship, Esther couldn't be in the room. She couldn't talk with the care team about next steps. She couldn't advocate for Kathy. She couldn't even hold her wife's hand. Then, when Kathy died, nothing. No one said a word to Esther. They had been together 33 years. I remember when I asked Esther what the hardest part of this whole thing was, and she said, "My wife was dying, and I couldn't even say we were married." What Esther's story shows is that communication affected the outcomes of two people. Kathy's care got worse. She didn't have the support or someone to advocate on her behalf from the person she loved, because Esther wasn't family. And Esther was shut out from healthcare discussions and decisions. She had no voice and ultimately no grief support. She was just the good friend, the emergency contact, not a grieving spouse who just lost the love of her life. And it turned out that Esther was so traumatized by the whole health experience that she avoided the medical system for well over a year, even though she had a growth on the side of her neck. So we have delayed medical care on the caregiver as well. Unfortunately, Esther and Kathy's story is not unique. This is a choice LGBTQ people face all the time in healthcare. Do I come out and risk being treated badly, risk not having my person in the room, or do I stay silent and hide a fundamental part of who I am? It's a heck of a choice. And on the one hand, we have very documented discrimination and disparities in outcomes. On the other, we have people who are professional hiders and who are understandably worried about sharing this information. And what I'm worried about right now is that the current environment is creating even more fear. And more fear could push even more people into the strategy of silence, which could lead to more disparities, more bad outcomes because of communication. But communication is actually one thing we have a lot of control over in healthcare and our daily lives. And even if it might seem like a very small change, a form, a question, the way we listen, it can make a huge difference if you're LGBTQ. Let me give you a couple examples that I've given. If you think about how we learn about patients and those they love, some of these forms and intake questions, they can be very scripted. Are you single or married? Are you male or female? Who's your family contact? If your life fits the script, these questions are fine. But if your life doesn't fit the script, they can be very limiting and can shut you out pretty quickly. We often don't think about it, but a lot of these questions too can be loaded with assumptions that aren't always heard, not always spoken, but they're definitely heard. Just the question around married. We don't care if someone's legally married. And the thing about LGBTQ seniors is a lot of them never did get married. For most of their lives, it wasn't legal. So when we talk about married, they might only think, it means legally married. It might not give the information that they need to share. But if we think about what we really need to know, which is not someone's marital status, it's really about the who. Who do they want in the room when we're talking about next steps? Who will be helping them at home? Who will they trust to make healthcare decisions if they're no longer able to? So one way to start thinking about breaking some of these scripts, like around marriage, is just changing it to say, do you live with anyone? Or opening these questions up. Who's the biggest support in your life? Just think how different the outcome could have been for Esther and Kathy. Another script and word we use a lot in healthcare is just around the idea of family. But like marriage, family can have a lot of boundaries that can box people in and box people out pretty quickly. As I mentioned earlier, countless LGBTQ people have been cut off by their families. And so if you say the word family and they might only think biological family, they might not give you the information that you really need to know, again, which is the who. So other ways of getting at the who do you want with you when we talk about your care? Who will need support so they can support you? Who are your people? Another really part of healthcare is, and especially around serious illness and end of life, are advanced care planning conversations or goals of care conversations. And these are critical tools because when they're telling us what a patient wants and what they don't want, things like CPR, feeding tubes, etc. But there are other things that also matter to patients that are important to them, but are often not part of these usual scripts. Another example is a woman I met. Her name is Janelle. She transitioned in her 60s, and she told me about some of her biggest fears if she were to get sick or enroll in hospice or face serious illness. This will play. Here she is, and you'll have to listen carefully because you can hear the fear in her voice, and she gets quiet at the end.
As far as palliative care, yeah, I do have concerns. I'm worried that certain things will be outside my control at that point. And I
What do you mean, like?
Oh, like I still have to shave, for example. I don't want hair on my face.
At the end, when she gets quiet, she says, I still have hair on my face. I still have to shave, excuse me. I don't want to have hair on my face. And here's Janelle again.
I will be perfectly honest that one of the things that I thought about a lot before I transitioned was I don't want to die this way. You know, I want to be buried as a woman. I don't want to be buried as a man. I don't want a man's name.
At the end, she says, I don't want to be buried as a man. I don't want to have a man's name. I shared Janelle's story to think about some of the forms you filled out, you've given patients to fill out, or some of the questions you've asked, and thinking about where there would have been space for Janelle to share information like this, and whether she would have felt safe to disclose this type of information. Now more than ever, it's really important in healthcare to let people know that we're safe, and really being aware of our communication at every level. Written communication, letters, forms, and websites, spoken communication, like these intake questions I've been talking about, or different forms. All of these can signal and show that you're safe for LGBTQ people, which can give them the space to share critical information about their care. It matters at an individual level and also an organizational level. Your team, your clinic, your institution, your organization, and also your home, your family, and your community. Simple things help a lot. These pins and lanyards and signs for your walls and lawns go a really long way. And you might be thinking, like, I can't believe this person has come from Colorado and told us all these horrible disparities, and she's basically telling us to change a couple questions and wear a pin. And partially that is true, because the truth is it's going to take a long time to address some of these deeper disparities. But the other truth is we have a lot of control and power with our communication. And a lot of these disparities are traceable to communication and a lot of the biases. So if we can help get the biases out of communication, these actually can make small wins. And a good friend of mine, Naomi Goldberg, who is at the Move and Advancement Project, came to give a talk in one of my classes, and she talked about how we really need to think about winning and redefining what winning looks like right now. And part of these signs and symbols and questions are really small wins and really thinking about what winning differently can look like. Because also, one by one, as these questions get asked, as more pins get seen, they can make a significant difference. And right now, that feels like a major win. And the other thing about signs and pins is that LGBTQ people are trained to look for these. As small as they are, we will find them. They've been doing it their whole lives. It was really the only way people knew if someone was safe or if they weren't. And they needed to know who was safe and this hasn't changed. But it becomes critical especially when patients are older, and especially when they're facing end of life or chronic health issues, which is often when they need to go into places like assisted living. Assisted living communities are also one of the places where stigma and discrimination are a major problem for LGBTQ people. As I mentioned before, many LGBTQ people don't come out until very late, their 70s or 80s. And if they do come out, 75% go back into the closet when they enter long-term care or assisted living. 75%. About 2 years ago, we got a grant in Colorado to do some trainings at 6 Denver faith-based assisted living communities. And the goal was really to help these communities become more inclusive for staff and for residents. And we got a lot of pushback from leadership and from staff. We couldn't say the acronym LGBT. We couldn't show a rainbow on any of our materials. Leadership told us there was literally no need for the training because they didn't have these types of residents or staff. After a year of going back and forth, and at this point I was getting pissed, they gave me 45 minutes to go into their communities and tell them why the project mattered. So as a researcher, I was like, bring it. I have all the data and statistics to let these communities know just how hard it is and how necessary this training was. So I shared terrible statistics, a lot of the statistics I've shared with you tonight, about how LGBTQ people are treated, their experience in healthcare, their discrimination, their fear, including assisted living communities. I tell them about the stress and the impact it has on them, and the fact that it takes up to 12 years off their lives. All of it and nothing. Like, it was like all the data just floated right past them. Nothing. Every once in a while, I would get a couple questions. And I remember one of them would ask, why would anyone choose this lifestyle if you knew you would lose up to 12 years? Another person asks, will there be less gay people now that more and more people are eating organic? My message was not getting through. Like, no one could see that these were real people I was talking about, that there were real people behind these numbers and these statistics, and that a lot of these people live with them, took care of them, worked with them. After the organic question, I drove home realizing I needed to do something different. Like, these numbers and statistics were not working, and they were just too abstract. I needed to break open these stereotypes that felt like they had been cemented in their heads, to figure out a way to really help these people see that these health disparities were impacting very real people, human beings in their communities. When I told someone I work with about the organic comment, she asked if I got mad or yelled back. And in my head, I was first thinking, how am I going to yell at a 70-year-old? And also, what good would that do anyway? So I told her no. I was just quiet, and I let her finish. Because the truth is, I was in those assisted living communities to learn as well as talk. I wanted to hear about their concerns from staff and leadership and other residents. How else was I going to understand what their biggest worries were? And how else was I going to understand where they were so we could actually meet them where they were to do the training in a meaningful way? I think the woman also who made the organic comment was truly convinced she had never met someone who was LGBTQ, even though I was in the room with her. All she had were these stereotypes. And here I come throwing all these statistics around about LGBTQ people, and she could not picture the people I was talking about. People like Shirley, people like Esther, people like me. There was no link for her to make, zero, below zero connection. So that night, I reached out to about 30 LGBTQ women I'd interviewed for another project and asked them if I could take their picture. I thought maybe it'd make a difference if people could just look LGBTQ people in the eye, see for themselves that these are real people who are being impacted by these numbers and these disparities. People who look just like their sister, their cousin, their neighbor. And all the women said yes. I had no idea what I would do with these pictures, but I showed them to a couple friends I work with, one who ran the bioethics and humanities department, and the other one who organized our art exhibits at a gallery at the School of Medicine in Colorado. And they loved it. And we installed the exhibit a month later, and we called it Eye to Eye, Portraits of Pride, Strength, and Beauty. Because we hung the photos at eye level, so you literally look women, all these women, in the eye when it's hung. Eye to Eye, which has 27 black and white pictures of older LGBTQ women, has now traveled around the state of Colorado. It's been in churches, art galleries, libraries, and has been featured in all kinds of news stories, including the USA Today. I've been doing research for a pretty long time now, and as I mentioned yesterday, I think maybe 10 or 12 people have read some of my top articles. And as I also mentioned, most of those 10 are most likely my students. But hundreds have seen this exhibit, and hundreds more have read about the exhibit and read stories about these women, which are stories of hope, of beauty, of courage of LGBTQ people. Stories that really humanize this community. And the exhibit is still going. It's actually going to be hung at the Denver International Airport in June. It's totally wild. And every time I hang this exhibit, I'm like, and the news stories start, I'm like, who would have thought that these pictures I took on my iPhone during COVID, out of frustration, could do what I'd been trying to do for 14 years as a researcher, connect data and people. I'm not suggesting that you all leave tonight and go create a photo exhibit. But I am saying that stories are a really powerful way to unravel stigma and illustrate what we actually mean when we talk about health disparities. Real-world examples help people see the individual impacts behind these numbers and statistics. So as I get ready to close, I hope some of the stories I've shared tonight stay with you, about Esther, about Janelle, about Shirley. And I hope you remember that this habit of silence still exists and is very real. And it deeply affects the way LGBTQ people move through the world, and especially as they interact in healthcare. And it will not go away unless we all start pushing back, breaking these scripts, opening up space in our conversations with friends, with family, with colleagues, with patients. We have to be proactive here at every level right now, because the fear is very real for LGBTQ people. And fear is a huge barrier to having a healthcare system where all can thrive. I've actually heard and spoken the word fear so much recently, I looked up the definition for this talk. It's an unpleasant emotion caused by the belief that someone or something is dangerous, likely to cause pain or a threat. After hearing the stories of hundreds of LGBTQ people and looking at the data, I've come to understand just how much fear has contributed and still contributes to their health and their care. And unraveling this fear through communication is one way to rebuild a healthcare system where more people can actually thrive. Every single LGBTQ person I've met in my career is not asking for a lot. They just want to be able to talk openly and be heard without prejudice and be listened to. And thank you for listening tonight.
Is this mic on? Yes, great. Thank you very much, Dr. Candrian, for that wonderful presentation. Hi, everyone. I'm Erin Cross. I'm a professor of medicine at the University of Washington and director of the Cambia Palliative Care Center of Excellence, and I'm going to be moderating the Q&A portion of tonight's event. As a reminder, questions can be sent in on the Slido using the QR code. I don't know if I imagine eventually, will that be put back up on the screen? Or you can use, for those of you online, you can use the link that's in your registration reminder. Those in the audience can come up to the mic. I'm going to be using this iPad to look for questions that are being submitted by the online audience. I might interrupt those that are in line here at the mic to interject questions that are coming from the online audience, but we have lots of time for questions. So I'll open up the mic here to the in-person audience, and then I will start looking for online participation.
Hi.
Hi, James Fesselbaum, former employee with UW Pulmonary Critical Care and Sleep Medicine.
Oh.
So being an out gay man in Seattle, we are privileged to have wonderful medical care at UW Medicine. I'm glad we have a choice because it's really stupid because I used to trust Providence Swedish, but since it became faith-based, I've lost trust. Can you speak about the research you've discovered takes into consideration like red state, blue state, or access to non-faith-based medical care? Because I feel like, I acknowledge the challenge that the subjects experienced, and not to say that I haven't experienced discrimination, but I feel relatively lucky that I can go to UW Medicine and not get discriminated against.
I'm glad you can too. And the reality is so many hospices, so many assisted living communities, so many hospitals have become faith-based. The assisted living communities we worked with have all been faith-based communities, and they are a huge barrier for the very reasons you said. As soon as you see something religious, it sends all kinds of triggers for LGBTQ people. But it's really hard to avoid them. I haven't done specific research on red and blue states and faith-based and non, but what we have done is actually show that it is effective. That there are people in these organizations and communities that do want to be protective and safe, and finding those people is really critical right now. We were able to end up starting a gay and straight alliance for these communities, and so I think it just requires more work and more creativity, and also on LGBTQ people to also be open that some of these faith-based are not, always out, even though I say that with great caution, but there is potential to also have, good experiences there. It just it must look different. And I think it is important for people from a marketing perspective too, to know that that does something to LGBTQ people when they see that. But especially some of ours are mostly the only Medicaid ones too, which is ends up being the only option for LGBTQ people. So it's a great question and a lot of work that still needs to be happen.
Okay, from the online audience, we have a question. What aspects of the healthcare system do older LGBTQ adults consistently describe as the most difficult to navigate?
Ooh. Pitch that to the audience. One thing that I've noticed is just, thinking about the disparities, about the lack of resources, both financially and support, that does come up a lot as being a very difficult thing to navigate when you don't have financial resources and also potentially advocates. And I think just the disclosure becomes a huge difficulty around healthcare. Knowing whether it's safe or not is a huge barrier that this community continues to face as they navigate. So not only are they worried about getting care, but then can I be out? Can I be safe? All these other factors that come into play become very burdensome very quickly. Hi.
Hi, I'm LB, they, them. We know that community important for everybody, but particularly for the LGBTQ community, and we kind of take care of each other. Mm-hmm. I'm curious, especially for older adults who, if they're moving to assisted care and they're sort of losing that community, how can, the healthcare community, how can we continue to foster that and see that as integral to healthcare, especially for our population?
In assisted living
In general, I think we don't often think about community and its role in healthcare, but
Great.
it's super important.
It's super important. Thank you. I mean, we've talked really about that it is a protective factor, particularly for this community, for anyone. I mean, community is really a protective factor for so many illnesses and ailments. I think, I mean, one of the conversations I had earlier was really just sort of where to help, this isn't the case, older trans folks in the community, of where to go to get support. And I think being able to have these resources readily available, I know Gen Pride is a great resource in Seattle, to know where to send people and to not undermine the significance of that, because aging is already lonely and isolating, and as you know, it gets exacerbated when you are older and also LGBTQ and add on any other intersecting identity. I think just exactly what you do. I mean, just starting to talk about the role that community plays, and even asking that, what do they have? Do they feel like they have community, and giving them options of where to go, I think is a great start. And using these communities and making it sounds like there's a great relationship, but continuing to build the community resources with healthcare, I think is critical. It's a great question.
People online want to know if you eat organic.
That is so funny. I mean, I live in Colorado. Yes, but not always. I don't cheat in the bulk section. Actually, someone said that when they fill up organic yogurt almonds or something like that, do you use the PLU for organic or not? I use the correct PLU address, or whatever PLU address. Some people don't. So I've been told.
And then there was a question about, have you encountered in your work, or do you have thoughts about how intersectional identities, the question here was specifically focused on trans people of color, and how their experiences might be different, particularly among older trans adults.
Yes, that's excellent. And yes, and not enough of the work. I mean, it's just all these intersecting identities continue to make it even harder. Ability, race, ethnicity. So yes, and also I need to do a lot more. We all need to do a lot more, really thinking about how these intersect and continue to disadvantage people in all kinds of ways. Thank you for the question.
Hi, thanks for your work. I am a healthcare administrator. I work in an FQHC, and I've been doing a lot of thinking about, it's really hard. The rainbow pins are great, the forms are great, but there's also like a systems level thing that is really hard to get at in big places around like who gets cancer screening and all of that. Yeah. And so I've been thinking a lot about places like Howard Brown and the Lion Martin Center, and this maybe is a little bit red state, blue state, but did you do any research into their Medicare programs and what the impact is to have kind of LGBTQ-centered health versus it being a kind of like add-on thing that people do?
It's a great question. I have not. I know people who have. I mean, what are the benefits are? Does it make a difference to go to an LGBTQ specific? Yeah. I have not. I know people who have, and it's different for assisted living. It hasn't been as conclusive, but for healthcare, it has shown significant results or significant advantages to having that. The reality, though, is like how many places can actually do that, and I think I am biased to thinking about how can we work within the systems we are and have them, despite all the challenges, become more inclusive instead of trying to focus on sort of just given how difficult it is to have specific LGBTQ places. But I'm curious your thoughts, if you want to share, or if you know.
I went to the UW and they told me, oh, you don't need a cancer screening because, maybe they were uncomfortable. And no shade to the UW, I know where I'm at. But we can't just assume that because it's not, because we think it's safe or somebody's wearing a rainbow pin, that we've arrived somewhere, because there is this sort of anybody can buy a rainbow, but it doesn't mean you've done the work. And so in some ways, like I get real tired of having the same 101 conversation. And I think much like the sort of cutouts on this, people do this sort of accessibility metaphor a lot, but if we build something and create systems that center the folks who are most impacted, it benefits everyone.
Yeah.
And so for me, I'm trying to aim for that, but I think we all have to do work that, especially now. So that's my answer.
Thank you. Thank you.
Hello, thanks for being here. I guess I'm just kind of thinking about when I was like in high school and you go and do community service and you go to like, an elder care center and you just kind of engage and interact. And I was thinking about what Elby said, my friend, about the community we have at our age, and maybe if you've seen any example of this with the communities, the long-term care and hospice and assisted living places where people have like shown up, I don't know, in a gay way, I guess, like to like be like, we're here too, like, I don't know. I kind of think that'd be fun.
Yeah, I do too.
Is that like, have you seen that like modeled anywhere yet?
Like group
like the way community service, like it would be basically like, hi, we're, the queer kickball team of, Cal Anderson Park, and we're here to just like share a little bit about ourselves and play bingo with you. I don't know, like, has that happened anywhere?
No, I wish it did. Like, you should do that here, and we should do it in Colorado. But it's a great, it's a phenomenal idea, because it's like, yes.
Yeah. Would that make a difference, I guess?
I think so. Dude, I will come back for it.
It aligns really well with the question online that says, have you seen LGBTQ folks in SNFs, hospice, assisted care who are at greater risk for poor care when they don't have other people checking on them, when they don't have friends or people, or they're lonely? And this could be a great intervention for that
Here you go.
loneliness, right?
Yes.
In building community.
Yeah.
Yeah.
I thought this connection.
You saw, it's
actually like a triangle connection already.
Yeah, that's great. Someone is asking if you've had the opportunity to see how people, maybe the people who were responding negatively to you when you went into the nursing home or others, when you came back, did you go back there with your eye-to-eye photo exhibit, or other people who've seen your how did they respond? Did opinions change? Did you get to see the impact of that in some of those specific settings?
That's a good point. I should have finished the story. We did go back, and we did get, they did wear pins, which was a big for them. But we actually made a short video for them because they didn't want to do trainings, but they were open for us to calling it belonging. We called it belonging. And we made a video called Caring for All, which felt also like belonging. And so we had some of the residents, Shirley lived there, and one staff member who was really afraid to be part of it. And we had a short 20-minute video, and then we had a learning circle. But it was great. I mean, we started to talk about these things. We started this LGBTQ group, which, as I mentioned, it stands for Life Gets Better Together, because we couldn't say LGBTQ, but it actually works and goes along with the belonging. And it's great. They meet once a month, and it's part of the program. So it has, the CEO is a huge ally. She reshares things, she invites us back. So it's been really great, despite how painful, but it's been a great learning experience, and actually how important it was to just be patient and really meet these people where they were has gone a really, really long way. We actually had a No Kings protest. It was great. Organized by the community, yeah.
How do you keep your research going forward given the current federal climate that makes all these words so taboo?
Aren't we out of time?
Yeah, I know. I was hesitant because that was such a high, but how do you make it work still?
And that one on a high?
Yeah, well, I can come back to one more. Okay.
It's a really important It's a really important question, and I'm sure a lot of other people are thinking about this. I've tried to spin it. I mean, I've had great mentors of really thinking about, like, I mean, how do you do this more creatively or think about other ways? And it has become, now it feels like an interesting challenge to still sort of do the work, and feels like a total act of rebellion to even be up here right now and to still do the work. So I feel like that's also like rethinking about it in those ways, also knowing, and also just trying to figure out, I've held on to that redefining what winning looks like, these one by one winning strategies, and just radically thinking about how to continue to do the work and reframe it, rethink it, and go in through these other systems and impact that way. So, yeah.
Any more questions from the audience?
I don't know if it's going to be a high, but it might be. I was curious about your time in Washington as a fellow, and how receptive the people you worked with there are to the message that you're bringing, assuming it's a similar message, or to these statistics, and whether or not, sometimes I like to imagine that the rhetoric is rhetoric, and that behind the rhetoric there's like really sober, like good-hearted people out there who just don't have the microphone right now. But did you find that people were, is there a cause for hope there? And did you find that people generally were receptive to what you have to bring? Thank you.
That is a high, we can end that on a high note. So I originally, when I did the fellowship, was thinking, like, not surprisingly, wanted to work with older LGBTQ people, and everyone said, like, it's actually a really great experience, you should work on Capitol Hill and get some other experience. And as I told Judy, I think I said the words LGBTQ like 7 times. I have said the word 7 times with the fellowship and just being on Capitol Hill, not because they're necessarily, homophobic or transphobic, but their jurisdiction was Medicare and Medicaid and climate change and things that were really falling apart. And a lot of the work really came back to messaging, which felt very receptive and adaptable. Like, how can we communicate these potential cuts and what was happening in a way that people could understand? And there are a lot of great people. I mean, it's been the best year of my life, career-wise, to really see that. I mean, like, to be around such great people, even if they don't have the microphone, and really thinking about the strategies and the work that they're doing has been remarkably inspiring. And I mean, every time I say I would go and went back, it moved me to really remember how much work is happening there, and how many good people are not only there now, but have been there and actually have some really good ideas. And so I wasn't talking specifically about LGBTQ stuff, but it was good. Period. I'm good. Thank you all for being here.
I think we're at time, and so thank you, Dr. Candrian. This was really a wonderful evening. Thank you for sharing yourself and your work with all of us.
Thank you all. Couldn't see you.